Hey everyone, welcome back. My name is Paul Cooper, one of the Cooper EMS fellows this year. You might also know me as MD4 out in the streets or on the radio. Today I want to talk to you about syncope. I think that it's not only something that we see every single day in our jobs, but it's something that we get lulled into a false sense of security with. Whatever you get hit out with, by the time you get to the patient, they're awake, they're talking, they look like $1,000,000 and they have no complaint. We're kind of stuck in this. Well, there can't be anything bad with you. You look great, you have no complaints. But it's really easy to forget that there can be a lot of darkness kind of lurking in the shadows of syncope that we should be aware of. All right, well, what is syncope? Well, we know you pass out, right? But it can be a little more nuanced than that. So you have a brief loss of consciousness. You have an inability to maintain postural tone, meaning that if you're standing, you fall. If you're in a chair, you slump over. But this is the really important part of syncope is that there's a spontaneous return to baseline without any intervention. So it needs to be spontaneous and without intervention. So if you do anything to the patient, then that's no longer syncope. So if, for example, there's a patient on a cardiac monitor and they have a loss of consciousness and we notice that they're in VT and we have to shock them out of it, well, that's no longer syncope because we had to do an intervention. Or if we notice that someone has a loss of consciousness and we check their sugar and it's really low and we have to give them sugar back to wake them up, that's not syncope anymore because we had to do an intervention. So spontaneous return to baseline without intervention is syncope. And how does that happen? Well, for whatever reason, there's a reduction in cardiac output. And cardiac output, think about as how much blood your heart is pushing forward to the rest of your body. So there's either a reduction in cardiac output, meaning that suddenly your cardiac output drops, or there can be a supply-demand mismatch of cardiac output. So you're exerting yourself, your body demands more blood from your cardiac output because it needs more nutrients and oxygen, and for whatever reason, your heart can't meet that demand. There's a lot of things that go into cardiac output and what augments cardiac output. And if you think about it more, if you have an engineering mind, you can think about it as a pump and a series of pipes, right? So you have the blood vessels that bring blood back to your heart. You think of those pipes bringing fluid back to a pump. Your heart is the pump. And then there's vessels or pipes that are going away from your heart to the rest of the body. One thing that augments cardiac output is heart rate or speed of the pump. That makes sense, right? If we're exerting ourselves, if we're going on a walk or run, working out, whatever, in the gym, your muscles need more nutrients, they need more oxygen, so the heart rate's going to increase to pump fluid or blood forward to the rest of your body. How well the pump works or how good the heart is squeezing is another factor that plays into cardiac output. You may have some patients that tell you, oh, my heart only works 15% or 20%. They're probably talking about their ejection fraction or how well their heart is squeezing, the CHF patients or heart failure patients. If those patients try to exert themselves and they can't meet that demand of cardiac output because their heart's not squeezing, they may have a syncopal event. And another thing that plays into cardiac output, well, in order for blood to be pushed forward to the rest of your body, you need blood coming back to the heart or coming back to the pump. So if you have a reduction in your preload or how much blood is coming back to the heart, then you're going to have a reduction in your cardiac output. So we oftentimes think of those patients in the bucket like volume loss. So hemorrhage or severe volume loss, vomiting, diarrhea, poor PO intake, that kind of stuff. But whatever reason, there's a reduction in your cardiac output. There's a reduction in the blood flow that's going forward to the rest of your body, including to the brain. And the brainstem is kind of the primitive part of our brain. It keeps us alive. It breathes for us so we don't think about breathing. It has our gag reflex. But also it has this network called the reticular activating system. And that kind of controls our consciousness. It allows our brain to be conscious and allows us to kind of do what humans do and have the rest of our supratentorial or other parts of our higher functioning brain working. And the brain's a very greedy organ. In just a few seconds without oxygen and nutrients, it's going to shut down. So a few seconds in a reduction of cardiac output or an inability to meet a supply demand, and it's going to shut down. And if that system shuts down, then we have the loss of consciousness. And then because it's syncope and you have return on your own, then there's eventually at some point going to have restoration of blood flow and consciousness. So perhaps you were exerting yourself and you were not able to meet that supply demand mismatch. And now that you're passed out, there's no longer an exertion. And now you can meet that supply demand. Well, you're going to have restoration of blood flow to the brainstem. Or for whatever reason, maybe there wasn't a demand mismatch and you just had a sudden decrease in your cardiac output. Whatever caused that ceased, and now you have return of blood flow and your consciousness comes back. Well, what causes syncope? Lots of different categories, and depending on what source you look at, might break these up a little more, might combine them a little more. But something I really want to point out here is that we very often jump to blaming vasovagal or orthostatic as an etiology to almost every single patient's syncope. If you ask the right questions or kind of lead them down a certain path because that's the path we want to go down, you can almost always get someone to say, yeah, it's worse when I stand up, or yeah, maybe I felt a little nauseous or weird beforehand, and then bam, slap vasovagal orthostatic on it. But the numbers here don't really add up. If we're saying that majority of patients we come across have vasovagal orthostatic syncope, then why do vasovagal and orthostatic syncope really only account for 30% of our syncope cases? The fact of the matter is that the vast majority of our syncope cases will never know what caused it. Almost 40% of patients have an unknown etiology to their syncope. 10% of our patients have a cardiac etiology to our syncope. 7% can be attributed to medication. So are you on a beta blocker and your heart rate can't increase? Are you on water pills and you're peeing out all your volume and now you dropped your preload? And only a small subset of these patients have a neurologic etiology of syncope. But the big takeaway from this slide is that be hesitant to call someone vasovagal orthostatic because that's only 30% of our syncope cases. You're much more likely to get a cause of syncope that you don't know what's going on or you don't know what caused it. But regardless of what causes syncope is deadly. Like I said, a lot of the times when we get to these patients, they look great. It's really hard to grasp this concept that syncope is deadly. How can someone who passed out and is awake and is now talking to me and have no complaints and they look like $1,000,000 and their vital signs are rock stable? How is it deadly? Well, when you look at the numbers, cardiac syncope, while only attributes for about 10% of syncope cases, increases your risk of death by 100%. So you're 2 times more likely to die than the general population if you had a cardiac syncope event. Neurologic, you have 50% increased risk of death. And even if you have an unknown cause of syncope, and we said that bucket's pretty big, right? Almost 40% of patients, we don't know what causes their syncope. Even if we don't know what causes your syncope, you still have a 30% increased risk of death compared to the general population. But the most important thing that we have to focus on is cardiac cause of syncope. Because 2 times increased risk of death is huge. And we have to remind ourselves that we're not in the business of saying this is probably orthostatic or vasovagal. We're in the business of having a worst first mindset. So our job is to treat patients as if they have the most deadly diagnosis, right? Every single complaint that we come across can be life or limb threatening. When you come into the emergency department with chest pain, my job is not to say that it's probably musculoskeletal. My job is to say that it's not a STEMI, it's not a dissection, it's not a PE. And that could be applied to the pre-hospital environment, and it can be applied to every single chief complaint we get, including syncope. Just to prove it to you, if you're having chest pain, is it just musculoskeletal? Maybe, but could it also be a STEMI or a PE or a dissection? Definitely. Abdominal pain, just the GI bug? Perhaps. Or are their guts dying? Are their organs dying? Is their bowel dying from ischemia? Do they have a AAA? Do they have a STEMI? And can leg pain ever be deadly? Sure can. You can have limb ischemia, you can have necrotizing fasciitis, a horrible deep space skin infection that has really high morbidity and mortality rates. You could have compartment syndrome. The list goes on and on. So every single chief complaint we have can be deadly, and we have to remind ourselves to work in this worst first mindset. And when it comes to syncope, that worst first mindset is cardiac. So we always have to assume that our patients who have syncope, who have risk factors, are cardiac until proven otherwise. And proven otherwise means proven in the hospital and proven in the ED. Oftentimes, I can't even prove it otherwise in the emergency department. They have to be admitted for continuous telemetry monitoring and echoes and pictures and all that kind of stuff. So for the rest of this lecture, I really kind of want to focus in on cardiac syncope because it's the worst first diagnosis. So it's really what we should be considering in any single patient we have with syncope. And when I think about cardiac syncope, I kind of break it down in my mind into structural causes of syncope and electrical causes of syncope, right? So is there a mechanical issue with the pump, right? Or is there some sort of electrical issue with the pump? When we think about structural causes, we think about valvular disease. Aortic stenosis is one of those classic ones that comes up on test questions all the time. And oftentimes patients will tell you they have aortic stenosis or have had aortic valve replacements. You know, that aortic valve is supposed to open and close very nicely, but over time it kind of gets stiff, calcified, and it can't open as well. So not as much blood flow is flowing forward. And if not as much blood flow is flowing forward, then more strain is put on the heart itself to pump against that increased pressure. You can have things like pulmonary embolisms or blood clot in the lungs, right? So if there's a big blood clot in your lung vessels, well, then your right heart can't pump against that. And if your right heart can't pump against that, then no blood's coming back to your left heart. And if no blood's coming back to your left heart, well, then no blood's going forward to the rest of your body, and you have a structural cause to your syncope. And you can sit here and say, well, if they have a pulmonary embolism that's big enough to cause them to pass out, wouldn't they most likely just be in cardiac arrest and die, and that wouldn't be syncope anyway? Well, it could, but remember we said that syncope can be from an acute reduction in cardiac output or a supply-demand mismatch. So perhaps you're sitting around, you're having some chest pain and shortness of breath, and sitting down, not exerting yourself, just enough blood is getting forward past that blood clot to feed your brain and the rest of your body. But the second you stand up or try to exert yourself, well, then that supply demand mismatch happens and then you pass out. Other structural causes of syncope, things like cardiomyopathy, dissection, tamponade. When you think about electrical causes of syncope, well, really any sort of dysrhythmia, any sort of tachydysrhythmia or bradydysrhythmia. So are you in a heart block, second degree, third degree, intermittent, second or third degree? Sick sinus syndrome, tachybrady syndrome, whatever you want to call it. Are you in some sort of fatal dysrhythmia like VTAC or a run of AFib and you snap out of it for whatever reason? AFib RVR, torsades. And then pacemaker is another thing to keep in mind. It's really easy to say, oh, you have a pacemaker, it can't be the electrical system in your heart, but the patient got the pacemaker in the first place because there was an electrical system in the heart. And pacemakers fail. Batteries die, leads are displaced, leads break. So just because they have a pacemaker doesn't mean that it can't be from their heart. In fact, if they have a pacemaker, I would argue that it was probably from their heart. What we're looking at here is an example of a structural cause of cardiac, or what could cause cardiac syncope. It's this cardiac tamponade. So you see here, all this black is fluid. This is the sac that the heart sits in. The heart should be right up against this bright lining right here. You can see here, this is the right ventricle. And because there's so much fluid and pressure in the sac, it's going to press in on the weakest part of the heart, which is the right side. Now, if the right ventricle is collapsed and can't expand, that means that no blood can get in it. And if no blood can get in it, then no blood's going to the left heart. And if no blood's going to the left heart, then no blood is going to the rest of your body. And the sexy thing to think about with cardiac tamponade is, stab wounds to the box, gunshot wounds to the box, the chest. But honestly, this happens more in medically patients. So cancer patients get this, end-stage renal disease, dialysis patients can get this, and rheumatologic patients, like lupus patients, can get this. Just to put aortic valve stenosis into kind of a pictorial representation, you can see here in a normal aortic valve, it's nice, it's big, it's open. That area that the blood flow is flowing through is a lot of surface area. When you get stenosis, you get kind of like crusty, stiff valves that won't really open or close. So that surface area is reduced. So less blood's going forward and the heart itself is pumping harder. Real life aortic valve stenosis. This heart is obviously not pumping any blood. So if this valve were normal, it should be nice, closed, and relaxed, and all the valves should be touching nicely. But you can see it's kind of stuck up in one position. This is a really cool picture. Well, doesn't really happen that much anymore in the age of thrombolytics and PCI or stenting, but this used to be a really feared complication of heart attack. So you can see here, this patient probably had a pretty big heart attack or STEMI, and all of this darker heart tissue is dead tissue. It gets weak as the heart's pumping. It can cause the heart to rip. So this is kind of like a full thickness tear of the heart. And I guess technically this wouldn't be syncope because if this happens to you, you're almost 100% dying, which would not be a spontaneous resolution of baseline. So it wouldn't be syncope, but it's still a really sweet picture to look at. And then you can see here, this is a picture of a ultrasound of a heart. This is the left ventricle. This is the left atrium, and this is the aorta, aortic outflow tract. In a normal heart that's beating, these muscles, the left ventricle should squeeze. This compartment should close down, and this valve should kind of slap open more towards this septum here of the heart. And that kind of tells us the heart is squeezing well, but you can see not much is moving. The heart's really not squeezing very well. That valve isn't moving very well. So this person has reduced ejection fraction. So perhaps if they tried to exert themselves, their heart wouldn't be able to mount a response. They would have a supply-demand mismatch of cardiac output and have a syncopal event. And then electrical syncope, from a kind of microscopic level, you can see here normal healthy hearts, all that red, all that pink, that's more normal healthy myocytes or heart muscles. And those are designed to play very well together and pass electrical signals very well together. So we know the electricity starts up in the atrium of the heart, and then in an organized fashion kind of goes down through the septum and then through the rest of the ventricles to cause a nice, controlled, organized heartbeat. Well, over time, when you have heart disease, and say you've had stents or heart attacks or some sort of coronary artery disease or ischemic heart disease, well, when those tissues get injured, myocytes don't grow back. That's just replaced with kind of fibrotic scar tissue. And fibrotic scar tissue doesn't really conduct electrical signals very well. So it's possible that you're going to get either very irritated myocytes that aren't getting signals passed to them, so they're going to decide to try to start their own electrical beat, or you can get situations where electrical signals are coming down and somehow it gets trapped in an area of myocyte islands, and then all of a sudden, bam, you kind of have a vicious cycle, a chain reaction, and the patient is kind of flipped into VT. All because the muscle cells aren't really talking to each other the way they should be. Just like with any diagnosis or any sort of chief complaint we encounter, the history really is key. So if you have someone with syncope and they're telling you that, oh, they've had, heart surgery in the past for valve replacements, or they're really short of breath on exertion, or their symptoms have been kind of progressing over the past few months. A few months ago, they could climb 10 flights of stairs, and now they can only climb 4 stairs. This should really kind of make you think structural cardiac syncope. If you have someone who passes out and wakes up and they say, yeah, like I have a family history of sudden cardiac death, or I had a few heart attacks before and I have 4 stents, well, that should make you really worried for an electrical etiology of syncope. Sudden events and events without prodrome should really make you worried about electrical causes of syncope. And any sort of exertional syncope should make you worried about either structural or electrical, but definitely cardiac. When it comes down to it, the bottom line is that any sort of sudden syncope, any sort of syncope with chest pain, or any sort of exertional syncope is really, really bad. If you don't take anything else away from this lecture, take this slide away from this lecture. If you have syncope with chest pain, exertion, or sudden syncope, it's very, very, very bad. You should be very worried about that patient. All right, well, what if they felt like they were just going to pass out? Well, it doesn't really matter. Syncope and near syncope, they have the same pathophysiology. They have the same risk factors. They have the same outcomes, the same increased risk of death. Near syncope is syncope. It's treated the exact same. You should treat it the exact same. Well, putting it all together, let's refer to our indicators and why our indicators are the way they are. So syncope and near syncope, because they're exactly the same thing with any of the below. Age over 50, older patients are more likely to have both structural and ischemic heart disease or electrical problems. Abnormal vital signs, that's kind of a given. Someone had a syncopal event and they wake up and their heart rate is 30, well, perhaps they're in a block. If their heart rate's 150, 200, perhaps they're in some sort of tachydysrhythmia. Multiple episodes, there's a reason you're having recurrent episodes of syncope and you need more evaluation. You need EKG, you probably need IV access, and to prime yourselves to take care of this patient in case they decompensate into cardiac arrest. And then associated with physical exertion, we just spent the last 10 minutes talking about bad structural and electrical etiologies of the heart. Exertional syncope is bad, 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 bad. And so, well, why do we need ALS? The patient's already awake, they're talking to us, they have no complaints. What's ALS going to do? Well, the patient needs an EKG and they need continuous cardiac telemetry monitoring. Not only because it's the right thing to do for this patient, but it's because it's the standard of care. When they come into the emergency department, they get an EKG and they get continued cardiac monitoring. Remember, EKGs are kind of only a snapshot in time. So it's very possible that someone is going in and out of abnormal heart rhythms. And when we take the EKG, that heart rhythm happened to be normal and it looks fine. And then 5 minutes later, the monitor starts beeping because now they're back into their run of VT or the run of whatever tachydysrhythmia or bradydysrhythmia that they're in. So not only is it right for the patient to provide the standard of care, but we have to remember that, we're healthcare professionals and that we're held liable to the care that we provide for our patients, so we have to meet the standard of care. And EKGs are quick, they're easy, and they're cheap, right? And they can pick up a lot of really bad things. STEMIs, heart blocks, tachydysrhythmias, Brady dysrhythmias, and a bunch of other things that can clue us into cardiac etiologies to syncope. First glance at this EKG, you might think it looks pretty good, but if you look a little closer, you can notice that QT segment's a little long. Long QT is a congenital, well, can be congenital, but it can also be caused by other things like electrolyte abnormalities and certain medications can set you up for torsades or polymorphic VT. Just a more exaggerated example, long QT. Brugada syndrome is kind of an inherited channelopathy. The sodium isn't conducted right in the heart muscles, so it leads to abnormal heart rhythms, and you can go into kind of tachydysrhythmias and VT a little easier. I'm not saying I want ALS providers to be able to look at this EKG and diagnose Brugada, but I want you to look at a patient who's had syncope, do an EKG, and say, that looks abnormal, you're staying on my monitor. Because chances are they might go into a fatal dysrhythmia that requires prompt defibrillation or cardioversion. And some common pitfalls that we often walk ourselves into is saying they're just dehydrated. Did you drink anything today, right? We're trying to lead them down a path to say it's orthostatic, but only 9% of patients are orthostatic syncope. And they've had this happen before, so it can't be bad, right? Well, that's probably worse. They've had this happen before. There's something not diagnosed, or there's something bad going on with possibly their cardiac system that's causing it to happen. And they're not really sure they passed out. Well, that doesn't matter because syncope and induced syncope are exactly the same. And they're awake now. Great. I'm happy they're awake now. Let's get them the care they need because it's very possible that in 5 minutes they won't be awake anymore. All right, as always, if you have any questions, please reach out to me, send me an email, find me in the emergency department at Cooper, find me on the street. Always happy to take questions and answer anything. Remember, syncope